or needle could have given us, but what is the use? Chemical decompression is the treatment. See, you have given a way of diagnosis. Good afternoon, everyone. Today I am going to present the rare case of respiratory. A rare case of respiratory distress in newborn with pylothorax. This is a case of baby of Renuka born to non-consensus marriage, 34 weeks of gestation age, that is, it is a preterm baby with birth weight 2.2 kg, male child. Coming to the antenatal history, maternal age is 35 years, primary mother. In view of preterm onset of labor, mother was given 2 doses of antenatal steroids. As soon as of the birth of the baby, required resuscitation in the form of bag and mask ventilation for 30 seconds. Abdomen at 1 minute and 5 minutes was 6 and 8 respectively. Baby was brought to our hospital at 2 hours of flight with chief complaint of respiratory distress since birth. On clinical examination, we found that tracheal shift towards right side, increased ASP on left side, heart sounds present on right side. So clinical impression on by this examination was there is medial sternal shift towards right side, maybe due to left-sided pleural effusion. Baby was immediately shifted to NICU at 2 hours of flight, and pleural effusion was confirmed with chest X-ray and ultrasonogram chest. Immediately to relieve respiratory distress, we did intercostal tube drainage. The pleural fluid thus collected was sent for analysis. This is the X-ray showing left-sided massive pleural effusion. We can appreciate shift of medial sternum towards right side here. Pleural fluid analysis showed high amount of triglycerides and high amount of cells with lymphocyte predominance. That means we are dealing with a case of pylothorax. Other evaluation to rule out the causes of pylothorax came to be negative. That means we did cardiotiping, we did fetal echo, ultrasound and toxicology, which came to be negative. So this is the clinical course. Immediately after drainage, there is complete empty of left side pleural effusion, and after few days, the medial sternum takes its normal position. We gave antibiotic treatment to prevent secondary infection, and we intubate the child to prevent excessive work of breathing, and we started on total parenteral nutrition. Volume and electrolyte hemostasis was maintained. Coagulation factors and immunoglobulins which were lost in the trial were replaced regularly with fresh frozen plasma and albumin infusion. Octreotide, which is a somatostatin synthetic analog, we gave octreotide because the thyme again reaccumulates. So to decrease the synthesis of thyme, we gave octreotide at an infusion rate of 0.5 micrograms per kg per hour. We did not notice any side effects of octreotide. We added medium chain triglycerides to the total parenteral nutrition to reduce chyle formation. Here, mechanism of action is these medium chain triglycerides, they diffuse passively among gastrointestinal tract and enters into portal system by bypassing the lymphatics, thus reducing the formation of chyle. Clinical status of the infant improved gradually with cessation of drainage on 12th day. With the extubation of the infant, thoracic tubes were closed and octreotide was stopped on day 14. So our management in brief, immediately to relieve respiratory distress, we did turbosynthesis and we provided supportive care in the form of mechanical ventilation, and to meet the loss of coagulation factors and proteins, we infused fresh frozen plasma and albumin, and to decrease the child protection, we gave octreotide and medium chain triglycerides. Coming to the discussion, pylothorax is characterized by accumulation of chylous fluid in the pleural space. Its incidence is 1 in 10,000 live births. It is an uncommon disorder, but it is the most common cause of pleural effusion in neonates. Males twice commonly affected compared to females. 60% of cases involve the right side of the chest. The most common cause being post-cardiac surgery. Other causes are congenital abnormalities of lymphatics, direct injury to thoracic tract, thrombosis in superior vena cava for any other reasons, and association with Turner's, Noonans and Downs. Criteria for the diagnosis: milky appearance of the fluid, pleural fluid protein concentration greater than 20 grams per liter, triglyceride concentration greater than 100 milligrams per deciliter, number of cells greater than 100 per ml with lymphocyte predominance and with sterile culture. Treatment is important treatment being initiation of total parenteral nutrition, rich in medium chain triglycerides, and hypoalbuminemia. We should treat hypoalbuminemia by giving albumin to keep the proteins level around normal, that is 3 grams per deciliter. immunoglobulins also. Role of octreotide, it is a somatostatin analog and used as an anti-secretory agent. It is believed to reduce the clanking blood flow and results in decrease in thoracic blood flow and triglyceride content of bile. If the patients are not responding to octreotide, then we will go for surgical treatment. Surgical options including thoracotomy, thoracotomy with thoracic duct ligation, intrapleural fibrin loop, pleuroperitoneal shunts. Conclusion: though congenital pylorothorax is a rarity, but it is the most common cause of pleural effusion in neonate. Wherever a neonate presents with pleural effusion, we should keep in mind about pylorothorax. Early diagnosis and initiation of management non-operative options and invention of surgical procedures decrease the mortality of pylorothorax from 50% before 1950s to 10 to 20% currently. Thank you.
In this particular case, what was the reason do you suspect to be the cause of
Maybe due to congenital abnormalities of lymphatic.
What is the use of this TOT serology in this case? TOT serology.
Ma'am, TOT serology is one of the etiology for hydroxycolase, ma'am. So pylorothorax may be a part of hydroxycolase. That's why we did TOT serology.
But did you have any follow-up of the case? Is the surviving?
Yes, sir. Baby is doing well, sir.
What's the current age of the baby?
How old is the baby?
6 months, ma'am.
6 months. For regular follow-up?
Yes.
Let us follow up.
The father pictures are also put, it would have been a further better presentation.
Due to that, we are instituting where diethylapamazine citrate and metronidazole. In fact, she has explained other etiologies other than filariasis. This is modern trend. Anyway, we still believe that in tropical countries, pylorothorax, filariasis etiology should be considered last.
Newborn,
right. Then next is, can you tell you what's the MCT diet?
Yes, sir. Actually,
What is the diet?
means
Is it available in Nalgonda?
No, sir. Actually, it's a part of parental nutrition, sir. It is available as a vial, sir. We should start it as an infusion, sir, to central mind.
Market, commercial
Sir,
market.
in Vizag, it is available.
Thank you.
Good afternoon, everybody. First of all, I'd like to congratulate all the organizers of this because it's been very good stimulus to create more and more new papers. Simply going to my paper, this is actually conducted in Department of Environment as well as thank the microbiology department for their contribution. The paper is Gene Expert Empiric Test. This Gene Expert test is a new test. This is also called as CBNAT. CBNAT means cartridge-based nucleic acid amplification test. And in this test, we want to compare this new test with the already existing test, which is nothing but, as you already know, sputum per AFP test, which is in use since very long time. This paper has been presented previously in national conference in the last November 2014. So as you know, TB is a major global burden. Its incidence is more than 9 million new cases every year, and it causes death of 1.7 million cases each year. Smear microscopy at present is the cornerstone for the diagnosis of the tuberculosis, but it has got its own disadvantage. The most important disadvantage of this is its poor sensitivity or modest sensitivity of 35 to 80%. And the cause for that is it can detect tuberculosis only if there are 10,000 bacilli per each ml of the sputum sample. Suppose if there are 1,000 bacilli are there, still it's tuberculosis, but it will fail to diagnose most of the time. That's the major limitation of sputum per AFP, in which we will be misdiagnosing cases or missing cases or even not able to prove microbiologically with mere per AFP in cases where the chest X-ray is very obvious of pulmonary tuberculosis. But given the fact that the most important advantage of this test is that it is very rapid test. You will know the diagnosis instantaneously within 1 or 2 hours immediately. the gold standard of tuberculosis for tuberculosis is culture. In culture, the major advantage is only 10 bacilli per ml is sufficient to make a diagnosis of tuberculosis. That's the major advantage. But the most important disadvantage is the time that it takes. It takes more than 3 to 6 weeks and even more if we want drug susceptibility test. The drug susceptibility test which is done is an added advantage. So this CBNAT test is a mix of these two tests. That is, it gives the advantage of both smear for ALB as well as the culture. The advantage of smear for ALB, that is a rapid test, it gives the result within 2 hours. Just 2 hours are required for this. The other advantage is it gives the drug susceptibility test result. That is whether the rifampicin resistance is there or not. And the other advantage is its high sensitivity and specificity. So this CBNAT test in India, FIND organization has started it in about 1,000 places. One of the places in Andhra Pradesh is Vijayanagar, not in Visakhapatnam. It was kept in Vijayanagar. In district hospital of Vijayanagar, this CBNAT has been made available, and all the sputum tests in the entire Vijayanagar district were also sampled for CBNAT test simultaneously. And in our study, what we have done is all those cases of tuberculosis suspicion, we did sputum for ALB as well as we did the CBNAT, and that's what is this paper. So this CBNAT test, it gives results of 2 things. First thing is, it detects the presence of tuberculosis or not. That is the first thing, whether the TB is present or not. The second thing is, it tells regarding the resistance pattern, whether the tuberculosis is resistant or not, because especially now the MDR TB is on very much rampant. This is the CBNAT which has been instituted in our district hospital. These are the, so you can see there are 8 cubicles which can simultaneously be operated. This is the report, the conventional report. You can see this is the smear report, positive, positive. The CBNAT is given as a stamp, and this is the positive, and this is about the resistant pattern. So I would like to give an example of 2 cases. In 2 cases, you can see here there is lots of infiltrates which can tell tuberculosis, but in this report of this patient there was negative in sputum, but it was detected as positive with the help of the CBNAT. The resistance was not there, it was sensitive only. Similarly, another case, we can see in X-ray that there is a cavity. The report was negative again in the sputum, but it was positive in the CBNAT. So that was the importance of this study. The objective of this study is to diagnose the tuberculosis among false negative cases, rapid detection of rifampicin resistance, and early disease management. So the study is duration period is 1.5 years, done from June 2012 to December 2013 by Department of Microbiology. All patients who have symptoms and signs of tuberculosis and chest X-ray of tuberculosis were included. Gene Lenson followed the gene expert assay was done. This is the test platform in which it is done. Here is the cartridge. This is the procedure how it is done. The results are total out of the 205 samples which were done. 109 were positive with the microscopy, but 144, much higher percent, was positive with the gene expert test. So this is the 22 contingency table in which we got about 70% of the detection rate with the CBNAT test, whereas it was only 53% with the sputum for ALT. And even rifampicin resistance was seen in 4 cases, which was not seen, which was even confirmed by sending the sample in the drug susceptibility test lab that is present in the GVCCD Vizag. So 4 were detected as rifampicin resistant. So the p-value came as very much significant. So in conclusion, it is more sensitive, much rapid method, and it avoids invasive tests like bronchoscopy in patients who are negative, and it requires just minimal training for this. So we have attended recently the RTCP task, I along with the professor of SPM, Dr. Das sir. There it has this study we have completed by 2013, but in 2014, now they are including this CBNAT as an algorithm, newer algorithm of the 2015, that I would like to say. So this is the, they wanted us to tell this to everybody to make it, so I would like to just tell briefly. We do 2 things, smear for ALB and chest X-ray simultaneously. If it comes as positive, there is no problem. But if it comes as negative, the chest X-ray is positive but the smear is negative, next thing is GX testing. It is nothing but the gene expert MTB testing. If it is positive, then we can start ABT. If it is resistant, then we can directly do the MDR testing, that is the drug accessibility testing. This was the older one. Thank you.
India also? Or associated with
Yes,
iron
so I would like to first of all differentiate between MDR TB and rifampicin resistance. MDR TB, it is resistant for both isolated as well as rifampicin. Whereas it can act, this test can act as a surrogate test where we can detect the primary MDR TB. So we are, at present what we are doing is, those persons who are started on category 2, we are sending drug accessibility test, LPA, litho test. But now the primary MDR TB is growing day by day. So yeah, that's why.
That is why this is applied.
That's why it is very important.
This resistance to rifampicin means MDR.
MDR also. MDR.
What is the material sent for this test? I heard this is a very costly test and not done usually in all the laboratories.
Yes, sir. Not only this test, the instrument is also costly, but it's costing 10 lakhs for each instrument. So material is only sputum. Actually, any material can be sent. I mean, pleural fluid, CSF, all can be sent. But because this is a pilot project, they told that it's only the sputum which we can use. Only the sputum was taken from it. Only pulmonary
Somebody
sample.
said FNSC material also can be used.
It can be used. It can definitely it can be used.
Because outside labs are charging
Yeah.
maybe for that.
Yes. So it was pilot project that we like that. But in future when it actually comes, then we can do this.
They took training here.
Yeah, it is free.